Get us started again. I hope you've enjoyed the break. You found the giant baskets of pastries, and that you're feeling caffeinated and ready, and also inspired, as I know we were, by the last session. Now we'd like to move directly to session 2, and that session is basically how did we do this? How did we go through the process to find a methodology and apply this methodology to work with the different communities that you've just heard from? And I hope also, by the way, you had the chance to watch the video of the satellite events that we had in country. That was something that was really meaningful for us to be able to make sure that the community had the opportunity to hear firsthand and discuss firsthand and hear how the time that they took and the effort that they made to contribute feedback and insights to the project really did make a difference. So now, having said that, we, as I said, want to move on to what is it that made this possible? What were the methodological choices, the adaptations, and the different decisions that were made along the 5 years of the project? And for that, I'd like to invite our colleague Michael Edelstein, Professor Michael Edelstein, also from Bar-Ilan University, as our last colleague Zielona. Michael is a professor of public health and epidemiology at Bar-Ilan University in Israel and a public health doctor specialized in infectious disease and vaccine epidemiology. He's also served as technical expert on immunization data and equity for governments in Europe, Africa, and the Middle East, and for the World Health Organization. And he is one of the principal investigators for River EU. So 5 years in at this point, and great to be up here with you today. Thanks.
Thank you very much, Alison, for the introduction, and very excited to be here and very energized by the previous session. I was speaking at the coffee break how rare it is to actually have voices from the fields coming to the heart of policy decision making in Brussels, and it's really valuable, something we should all think about. In this session, we're going to switch gears a little bit because in the intro, Janine showed us the results, the outcome of River EU in terms of improvements in knowledge, improvements in intention to vaccinate. And in the previous session, led by Zielona, we heard the voices from the field, the human side of what it actually means to implement these kind of interventions. In this session, we're going to talk a little bit more about how these interventions were developed, about the mechanism itself. And the mechanism that River EU developed is quite unique. It's all about adaptability and transferability, and this is what we're going to hear today. If you remember in the introduction, Janine talked a little bit about identifying interventions from the literature, from the body of evidence that exists, but of course these are not necessarily developed and adapted to the Roma community in Slovakia or to Ukrainian migrants in Poland. So we needed to do that work, and this is what we're going to talk about the experience of transferring interventions to specific context. And to do this, I'm going to invite 5 of our researchers from River EU. I'm going to start with Tamara Schloemer. Tamara is a public health researcher from Maastricht University in the Netherlands. And she's actually the architect of the methodology behind knowledge transfer, and she will tell you a little bit about it. Her research focuses on sustainable health system change and the use of participatory approaches and community empowerment to improve health in societies. So, Tamara, thank you very much. I would like next to invite Daniela Filakosvska. I'm going to try Slovakian pronunciation, but I apologize in advance. She's an associate professor at Pavol Jozef Safarik University in Košice. Is that right? There you go. I actually had to look up on the internet how you pronounce the little one. She works at the intersection of social epidemiology, health psychology, and public health. And her research is focused on health equity with a particular emphasis on improving access to care and preventive services in Roma communities in Slovakia. Next, I would like to invite Pania Karnaki. And Pania is the director of the European and international programs at the Prolepsis Institute in Athens, in Greece. Her background is in psychology and health promotion. and she manages the public health and health promotion projects at Prolepsis, focusing especially on health inequalities and marginalized population. I will then invite Professor Maria Ganczak. Maria is the head of the Department of Infectious Diseases at the University of Zielona Gora in Poland. And her research focuses mainly on different aspects of vaccination, but particularly vaccine literacy, vaccine hesitancy, and social and behavioral characteristics of vulnerable populations. And last but not least, Janine de Zeeuw. So we met Janine earlier on, but very briefly, she's a global public health expert at University Medical Center in Groningen in the Netherlands. And her specialist expertise is in uptake and access to prevention. Her work emphasizes interdisciplinary approaches to address equity with a particular focus on underserved community and capacity building. So a fantastic panel. And I would like to start with Tamara, because Tamara, as I said, is the brains behind the theoretical framework that enabled this transferability approach from interventions that exist in the literature to interventions tailored to particular contexts. So before we hear from the country team's practical experience, I would like to ask Tamara to tell us a little bit about the theory behind this transferability approach, and how what River EU did is a little bit different, how it differs from the way vaccination interventions are usually designed.
Yeah. Thank you very much, Michael. Introduce to you is the participatory transferability analysis. When we think about transferability of interventions, then we assume that we have a body of evidence, we have interventions that were proven to be effective in other contexts than our context. So we cannot assume that they are effective in our context with our underserved communities. And the approach that we used is a participatory approach. So we do not assume there is an effective intervention and we just transfer it and we think about how can we transfer it. But no, we ask the question from the beginning, can we transfer an intervention and which intervention will be helpful or useful to address the health system barriers that we have identified. So what we did is we looked at the body of evidence and we used 36 interventions and we assessed them for their needs-based usefulness. So we looked at the needs of our communities and built local advisory boards. And with these local advisory boards, the most useful interventions were pre-selected with regard to their applicability, for example, and how far they address the needs and how far they are useful from the perspective of the communities and other stakeholders. And then when we have these interventions, then we need to understand how are these interventions conceptualized. So we need to understand how they worked in the primary context, in the context where they were developed. This is why we had contact to intervention developers and asked them for specific criteria, specific questions that we took out of the PT models, the theory behind this participatory transferability analysis. So what we asked is, how did you do it? How did you develop the intervention? How did you implement it? How did it work in your context specifically? This is what we really need to understand before we can choose an intervention. And then we went into the field and we asked our participants, our community members, if we use this intervention, what do you think about the intervention? Would that help you with regard to the barriers that you face in your everyday life with regard to vaccination? And what do we need to change? What ideas do you have with regard to these interventions? So we use specific criteria to really identify facilitators and barriers for transferability, and what we might need to adapt or change, because we cannot assume that the intervention, how it is, will work in our context. And this is how we came to the need for adaptation and for decision-making. So it was a joint decision-making process. It was not, this is the body of evidence, this is the most effective intervention, and we'll use it and we will implement it. No, we really asked, what is helpful, why is it helpful, and how can we use it. And this is the essence of everything. And so I hand over to my colleague Daniela. And yeah, thank you.
Thank you.
Thank you, Tamara. Yes, so, Daniela, can you tell us a little bit, in practice, how did this whole process of transferability work for you? Just sharing a little bit the experience of the challenges, of how it succeeded.
Thank you for the question, Michael. Well, this whole transferability process is really demanding because you have to take several things into account, not only legislation in your country, but also the capacities of the healthcare system, and most importantly, the views and the visions of the community members themselves. So you need to balance this. And in practice, it meant that some interventions that looked very promising at the first glance were rejected by the community members. And I picked one example which was brought up by other stakeholders who suggested field vaccination. So through mobile vaccination teams that would come to the communities and offer the vaccination on the spot. And it sounded really logical because this would take off the burden from pediatricians who are already very overburdened in Slovakia. And also it would reduce barriers related to travels to the doctor. But it was kind of rejected by communities because it reminded them of COVID vaccinations. And at the time of the COVID vaccinations, this was done under very strict regulations. There were, it was period with associated with fear, with pressure, with unfair treatment, with loss of autonomy, because a lot of Roma communities were quarantined and surrounded by soldiers and police officers. So even though the intention itself was well-intentioned, the format triggered negative emotions. And also, one of the mothers said that this very much reminds her how veterinary doctors visit the villages and vaccinate dogs. And she said, I don't want my children to be vaccinated this way. I want my children to be vaccinated by her or his pediatrician who knows her medical history, her vaccination history. And this is something that was more trustful and emotionally safe for them. So that's why we rejected the idea of field vaccination. That's why we rejected the idea of school-based vaccination, which is not possible within our legislation. And these are the examples why we ended up collaborating so closely with health regions and with Roma health mediators, because this was actually what was desired by community members, and we prioritized their preferences.
Thank you. Pania, can you tell us about your experience in Greece? Was it similar? Was it different? What kind of experiences you had in implementing this transferability process?
Thank you, Michael. Now, Greece was a particular case because our target group were migrants and refugees, but that doesn't mean that all people come from the same group, from the same country. So there was a particular challenge there that we faced. Nevertheless, the participatory, the transferability analysis, the transferability process brought a lot of insight into our implementation team. We started by having a set of good practices that had come out from the research work of River EU. But then we took these to our participants, and to our surprise, we found out that we could not really just transfer the practices as they were. So we had to combine practices. We did find out that through the schools we had a very reliable venue, a very good venue in order to implement our work. But we also realized from the work that we did, from the analysis that we did, that people trusted healthcare professionals, for example. That was one of the big changes that we made. So we worked with both health promoters, trusted people of the community, but at the same time also healthcare professionals. The other thing that we realized needed to change was that healthcare professionals, even though they're experts in vaccination, needed to be trained into cultural competencies. So we had to develop a training for healthcare professionals before we could go in and start our work. And health promoters, who were trusted people of the community, also helped us in designing the training material that we trained our healthcare professionals in. Also, one of the things that we needed to adapt to our situation was the fact that, especially for HPV, a sensitive topic, we realized through the co-creation and the transferability analysis that we sort of had to change our narrative. So we emphasized the cancer perspective of HPV and didn't focus so much on the other sexual connotations, sexual implications. And that was very successful. We found out in the process that was really successful. And then one of the things that we also had to change was according to what group of people we were talking to, whether we were talking to from what part of the world, so that the material had to be adapted to our audiences repeatedly in our intervention. Thank you.
Thank you, Pania. When we work with communities and we're looking to create interventions using this transferability process, sometimes there are surprises. Things are not always, they don't always turn out the way that we think. And so adaptation and flexibility is a very, very important dimension of this process. Maria, do you want to tell us a little bit about things that you believed going into this process that turned out not to be true, maybe about the community itself or about the intervention, or even things that you discovered about the health system, and how did you deal with these surprises?
Yes, so I think that implementing such big project, you've got to think about some adaptations which may be driven by external and internal changes. And that's what happened to us. We first planned to address this project to Ukrainian migrants, economic migrants. So after 2014, there was an unemployment in Ukraine and unfavorable economic conditions, which made Ukrainians come to Poland just for work, and they were staying for like 3-6 months in our country. Then they were coming back to Ukraine to prolong their visas. So they were mainly males in productive age, in between somewhere between 20 and 45. But then after this huge invasion, invasion of Russian and full-scale invasion, an influx of refugees, we faced a change in the target population, because many women with the children, and what is worth saying, highly educated women came to Poland. And in the beginning of the invasion, there were 18 million of people crossing the border. So we had to reorganize our approach. And so it was the totally different target population, women and children. And another hurdle, another obstacle was, but it was not really an obstacle. It was more a facilitation condition, a facilitating condition. But in the beginning of the project in Poland, HPV vaccination was only 50% funded by the government. So for Ukrainian migrants, still it was a lot of money because they were struggling with everyday life. They couldn't afford it. And then we started our personal campaign due to the feedback we were having from them to let it be free. So just 2 years after we started the project, our government changed the legislation around this payment of HPV vaccine and vaccination. So it started to be completely free of charge, which was a great chance for Ukrainian migrants. Because they did not have to pay for a vaccine for 2 doses, which was really very expensive. And another internal change, which, of course, not everything can be anticipated, so we did not foresee it, was the fact that 1 week after a vaccination of a 13-year-old boy, he was hospitalized with viral meningitis. And very thorough investigations made by our local sanitary epidemiological station and by us researchers and also by clinicians excluded the causal effect of vaccine and this viral meningitis. But still, the message spread all over the community, and we faced a crisis in confidence. So instead of having like 20 people on the next educational session, nobody came. And there was a great decrease in the number of children showing up at the vaccination point. So we had to rearrange our approach, and we started to make them feel more confident, our Ukrainian parents, and we started to give them face-to-face education during their visits at the primary care clinic. So sometimes you've got to be very flexible, and you've got to monitor very thoroughly what's going on in the country, on the country level, on the regional level, but also on the community level.
Maria, thank you for these examples and for dividing it between external and internal changes. Janine, what about the Netherlands? Can you share some examples of adaptation as well? Things that didn't quite go as expected.
Thank you, Michael. Yeah, so to be honest, I think I, together with some other stakeholders, really thought for the Netherlands that a school-based intervention was a very promising intervention. But then through this whole process of transferability, the community members really voiced that school was a safe place for their children, and they really mentioned that they thought that would change if we wanted to go for a school-based intervention. And as was already mentioned by Daniela, also in our situation, the voices from the community were the strongest. So we really followed their advice, and that's why we decided to go for the intervention with health promoters, and then via the cultural setting where we offered the educational sessions, because school was very important and had to be a safe place. Also, what an adaptation was is that in the primary intervention, the health promoter led the educational session, and for the Netherlands, the community members voiced that it was important that also a health professional was present, just in case of any medical-related questions, or to ensure that if there was a need for additional information, that could be covered by the health professional. So that was also an important adaptation. Given the factors out of influence during the interviews, when we started in 2021 in the Netherlands, vaccination, HPV vaccination was for girls 12 years of age. And during the project implementation that changed, so the girls and boys were invited for HPV vaccination when they turn 10 years of age. But for the community, this was very important also, and we changed the target group, and for the community it was also very relevant, because all of a sudden it was not only something that affected girls solely, but also boys. So I remember the discussions we had during the training that this had to be highlighted for the educational session. So this was a change, but in the end it turned out to be good, I think, for the educational sessions as well.
In the previous sessions, we already talked a little bit about issues of sustainability, and here we see how much work goes into adapting and transferring knowledge from one setting to another, to develop interventions that are really tailored very specifically to a context. And when all this work goes into it, it seems really important that we don't let it go to waste, even though the project finishes. And this is often one of the key issues with sort of these project-based interventions. So I would like to ask the four intervention panelists, what are the next steps, and how do you ensure that the interventions don't just remain a project, but actually become embedded into the system and into the ongoing delivery of vaccines and immunization to your target populations? Daniela, do you want to start?
So for us, sustainability became possible mainly because the project lasted long enough to enable a real relationship building, and not only with communities but also with the partners. And we were lucky enough to already have existing relationship between our university and Health Regions organization. But over these 5 years, we were not only exploring barriers and designing interventions, and but also we were building trust and long-term cooperation. And I think that the key factor was that we had Healthy Regions on the board since the very beginning. They were not only involved in development and implementation of the intervention, but they eventually took ownership of the whole agenda around the HPV vaccination in marginalized Roma communities. So this means that the activities did not stop when the implementation phase ended in June 2024. Healthy Regions continued independently and integrated HPV prevention into their routine field activities and cooperation with healthcare providers. So within the project, we trained around 40 Roma health mediators and their coordinators. And since June 2024, Healthy Regions trained more 113 Roma health mediators. So this is almost a half of them, and they plan to continue till the end of the year to train all of them. And maybe the strongest evidence of sustainability is that since our intervention ended, they track their field activities with an application. So we actually know that all these trained Roma health mediators, after the end of our intervention, carried out almost 10,000 intervention activities, including educational sessions, individual consultations with families, communication with healthcare providers, and school-based activities with children. So for me, the sustainability is mainly about not about producing materials or educational outputs, but it's about creating functional model that is acceptable by the communities and then adopted by a strong institutional partner that continues the work after the end of the project.
Pania, what are your thoughts on
in River EU, we try to address system level barriers. And in Greece, we were able to find solutions for a number of these system-level barriers. For example, the need for more targeted awareness raising about vaccinations, also the issue of language adaptation, cultural adaptation, etc. We have developed these tools, and we aim to continue to use them. And we have in our institution and through our synergies that we've created through this program acquired some promises that these are important solutions that people at higher levels would like to see to continue. Most importantly, I would like to stress that we may not be able to influence policy change at a very high level, but we can do a lot of things at the community level. Already Mrs. Gavrili before mentioned that things have changed in her school. People are more acceptable. They come up with questions about health. So we intend to capitalize, to invest on this, let's say, community level opportunities that we have to use our results and to use our solutions with the migrant communities and using venues that are easy to access, like schools, like other community centers, because in Greece we didn't only focus on schools. We did a lot of work with other settings, including a workplace setting, for example, where we were able to go and speak to people, to mainly men who were migrants and refugees themselves, but we influenced them in a way that the spillover effect would be visible in their communities and their families. So our idea is to invest more at the community level and use the results of River Review EU at the community level. Thank you.
Maria?
Yes, I think that everybody remembers this movie Live and Let Die, with George Moore starring as the leading actor. So regarding this project, I just thought that we should let it live and don't let it die. So regarding our Polish arm of the project, I think that I'm an academic, so our task now is to produce guidelines and recommendations, but not very general like we did in the project, but specifically recommendations for Poland, for Ukrainians, migrants, refugees, and to put it in a very practical way with some graphs, illustrations, etc., to let everybody remember about the core achievements of the project, and to let them use it for their own needs. So we are going to write these guidelines based on our collaboration with different experts in the field of vaccination, virology, public health, epidemiology, pediatrics, and family medicine. And also, I would like to add that for my PhD students are now completing their PhD thesis based on some aspects of the project. So again, it will not die the idea, but it will be forwarded to the next generation of our young, enthusiastic medical workers. And also, we would like to more, or even through the project, we gave our Ukrainian community not a fish, but more a fishing rod, which means that now they are continuing our work on HPV in general. As Mofida mentioned, there is a collaborative project between Polish and Ukrainian gynecologists. So these women who are detected with some cervical abnormalities in Ukraine, they will be sent to Poland for colposcopy and for some other diagnostic tests. So we inspired them. It's not and this project is not our idea, but their idea, as a consequence of being awakened by the HPV and all these related issues. So this is from my side. Thank you.
And finally, Janine.
Yes, thank you. I think in the Netherlands we have been able to build an infrastructure where there is collaboration between the Multicultural Center and also the primary care services. And not only for this project, we see that the infrastructure that we have been able to build is very relevant, but also for other questions where there is, for example, a need from the community on information regarding another vaccine or maybe regarding another medical related topic. There is this collaboration, and I think that's super relevant also in terms of sustainability, that we know how to find each other and that it's easy to connect and that we can build upon these activities. And what I've also learned is that using this participatory approach, where we have really been collaborating with the community and with the health promoters, we have been able to empower the community. And it's not me or it's not us deciding on who to expand to in case of who we can focus on to expand the activities on the educational sessions, but it's really the health promoters that share with us what is the needs, what do they think is a next step, and then we can try to see how we can together continue with these activities. And this is also a request from the community members to expand the activities, for example, what Salima mentioned, to the Syrian community. But for example, also, although we now have been mainly focusing on mothers, adolescents in the Netherlands, up to 18 years of age, they can get the HPV vaccination. But what we've learned is that for adolescents with a Turkish or Moroccan migration background, when they are 19, 20 years of age, there is this question on that they are interested in the HPV vaccine, but then it's very expensive and then they have to pay. So we are thinking also maybe that this could be a very good target group. This was voiced by the health promoters to give educational sessions or to kind of remind them of this vaccination and give them additional education so that they can make an informed choice.
Thank you. So a lot of different examples of how these projects can outlive the time that we have allocated. We're a little bit behind schedule-wise, but you've been patient and silent all morning, and we really wanted to give the audience the opportunity to interact with the research teams that have been working in the different countries. So I think we can take one or two questions. If you have questions for any of the team members, please raise your hand and tell us where you're from, and please ask your question. Yes, please.
My name is Giorgio Barbareschi, and I'm from the European AIDS Treatment Group. So also looking from the lens, from the community side, and I think I come from a background which is very privileged in terms of interactions and engagement, particularly on sexual health. And I was wondering, because this is really very inspiring. I felt a little bit, maybe a missing link, I didn't see that, about the intersectionality aspects of this work, in terms of, also for instance, referring to the HIV field, we see that we, as a community, we are not a community, we are communities. And sometimes some gaps are within the communities. For instance, the fact that stigma related to sexual health or to specific communities aspects are transferred or resolved by the dialogue within communities. For instance, when we talk about migrants, LGBTQI+ communities, we see that the fact of having a forum where we can interact together, that really helps to leverage this kind of problems. Another things I was reflecting about is the aspect of indeed of empowerment. I'm really glad it came out, this word, now in the last intervention. I was wondering how much is given back to the community in terms of everything that has been provided in terms of input from the communities, and in this project, how the communities inform feedback specifically on the outcomes of the project, how they have been useful, how they have been relevant in terms of providing input, and in the future, whether you see the community being more proactive in terms of also working on aspect of vaccinations. We have example, again, sorry, referring to the field of HIV, but for instance, where the healthcare system was particularly difficult because of legal aspects or because of structural issues. We saw, for instance, around Southern Europe, but now it's expanded all over Europe. The community organizing in Checkpoint, where they brought outside of the hospital or clinical context the possibility to go and test for HIV, but for other, even for other counseling in general of sexual health, and provide information about HPV or other potential vaccines, where to go and how to connect. And this kind of intervention were led by the community, and the fact they recognize themselves outside of a clinical context were really taking had a very good impact in terms also of releasing some pressure from the healthcare system.
Before we ask the panelists to answer or comment, we can take one more intervention. Yes, please, at the back.
Good morning. My name is Riyad Karim, Assistant Director for Vaccine and Screening Equity, NHS England, London. I had a question and also a comment regarding the Slovak Roma Health Mediator model and sustainability. It's fantastic, and there's lots of transferability. Thank you, my colleague Opre Roma. I think it's really important that this is a very important community, highly ostracized and massive across Europe, with a anti-racism has a permanence in this community, and we also have an emerging Roma community within the United Kingdom as well, in London and beyond London. So what I wanted to just make a comment was, I think it'd be really helpful if we could share the learnings with regards to the Roma health equity. So it's not just a vaccine, but vaccine in the context, as we're all talking today about how health is holistic in that broad kind of spectrum, but actually linking in with the Romanian health, Romanian Roma, Slovak Roma, Czechia Roma, Hungarian Roma, UK British Roma, and through allyship here, we can actually build and understand a rich platform of best practice and also put pressure on the systems across, and the countries and the member states, who often say positive things that they're doing X, Y, and Z for Roma community, but then when you tap on the surface, you see a different reality, why having that community partnership, which you've also stressed. So I think that's one appeal, particularly with all the underserved communities. There's so much learning across Europe, and I dare say with the United Kingdom as well, being a member of the Council of Europe, with the Special Rapporteur of Roma, Georgios Stamitis, there are opportunities for us to continue this work with the Roma community and other underserved communities.
Daniela, do you want to...
And then we will come back to... Okay. Thank you for showing up here, and I really hope that we will be able to connect together with František, together with Healthy Regions. As I said, the relationships are there, the infrastructure is there, the experience is there over the 20 years of Health Regions working directly in the Roma community. So I will be happy to connect, so just come to me after the session.
Thank you for raising this point about the heterogeneity across the different communities. And maybe you can also react, but I really would like to thank you for pointing this out, because in the Netherlands we focused on the Turkish and the Moroccan community, two different communities. But what we really learned is there is huge variation within these communities. So indeed your point is very important, and we had many discussions about how to ensure that the information that we share with the community members is really having the correct words. It's very different how you inform the Moroccan community, maybe in Groningen, as compared to how you inform the Moroccan community in Utrecht, in another city in the Netherlands. But also across both communities, we had to ensure that the information was delivered differently. Because, for example, and please reach out to Salima or to Lam also and to discuss further, because the wording that we used for the Moroccan community was completely different as compared to how we did it for the Turkish community. So that really took a lot of time to develop that materials, but also to ensure that we selected the correct words, and then for the different communities, but also for within the community. So thank you. Yeah, and maybe to shortly response to the input on the results. It was already mentioned by Afsana, but we all organized satellite events. And in the Netherlands, we also shared the results. I was very insecure about how to share the results, because you have to ensure that the information that you share is also relevant to the community members. And we were able to discuss it, of course, with collaboration with the health promoters, with community members, and ask about their interpretation on why some items, for example, on the questionnaire were scored lower as compared to other items, how they reflect on the results. So that's how we collected their input. Yeah. Thank you.
Just a very quick comment. As I said, in Greece, the target group was really different, right? It was not homogeneous under any circumstances, and we knew that this was a huge challenge for us when we were implementing. But we did find unexpected allies, or that we were not aware of, and in particular, this was evident in the school. It's a multicultural school with students coming from families from very diverse countries, but they all do identify as teenagers, and they've all lived in Greece for a number of years. So we used them. Maybe it's not a good word, but they helped us. They helped us take back the message to their families in the appropriate way. So it was multicultural and very diverse and very different, but there are common words and common language that you can use if you have the appropriate people to support you. And in our case, it was the actual teenagers.
I may just add about diversity. Also, Ukrainian migrants and refugees are quite different, as I have mentioned. These economic migrants, they want more structured information, basic knowledge about HPV and vaccination. But refugees, especially women, well educated, they are more demanding, but in this positive meaning of this word, which means they ask for statistics, for randomized controlled trials results, for global perspective. So we've got to treat them with this sort of respect and this sort of information and knowledge, more advanced knowledge. And also there's a diversity regarding gender, because females, mothers, are more open for new ideas, and the issue of vaccination, not only regarding their children, their daughters, but also their sons. But regarding Ukrainian males, they are quite reluctant, and we had to spend more time with them, convincing them about the effectiveness of the vaccine and the fact that it is the vaccine that works against cancer, especially regarding their daughters. So you may see this diversity from different angles.
Thank you to all the panelists. I saw there were other hands up, but we're really out of time, so I suggest you approach them during lunch or during one of the coffee breaks for further questions. I'm going to close this session, but I would like to finish with just a very short remark, which is, after 5 years of working together, I'm still discovering new stories and new... you know, as an immunization professional, there are things that we take for granted, like, for example, school vaccination. Mobile vaccination sounds like a great idea, and today we learned that, well, maybe in specific context it's not, because it's reminding people of dog vaccination. You know, I would have never thought about something like this. So I think that one of the key messages here is, you know, don't make assumptions, and you really need to contextualize, and this is best done using formal and structured approaches like the ones that Tamara developed. And I think in the next session we're going to dive a little bit deeper into this idea of formalizing this process through the guidelines and the guidance that River EU produced. So thank you very much, and I'm handing over back to Afsane and Alison for the next session.
Yeah. Thank you, Michael. Thank you, panelists. So before we move on to our next session, we would like to ask this question from you. You've listened to our panelist experience with adaptation, and they had to be innovative and flexible in implementing their interventions. And now we're wondering, if you were to transfer one of these promising interventions for immunization in underserved communities,
so from one context to another, like we did, what would be your biggest concern about making it work? And I suggest you do this while you stand up and stretch your legs, because we're moving on to the next session. There is no break, so please stand up while you answer. Thank you.
It wouldn't be a good public health conference if we didn't ask you to stretch.